So good evening, everyone. I'm Dr. Kim Thornton. It's very nice that so many of you have chosen to join us tonight. I'm a reproductive endocrinologist, have been with Boston IVF since 1998, and have been in practice since 1991. So I have lots of experience, and thought we would use this platform this evening so we can answer questions, etc., so that we can have a discussion about various fertility concerns that you might have. So everybody's saying hi. Let's talk about primary infertility first. One of the concerns when couples come in for an infertility evaluation is, what's this fertility evaluation going to be like? And for those of you who've never had any sort of evaluation before, it's pretty straightforward. We want to take your history, obviously, and, identify if there's anything in your history that might elicit why you're having difficulty conceiving. So for instance, women who don't have regular cycles and are anovulatory, that's problematic because if you don't ovulate, then you're going to have difficulty conceiving. Likewise, if there's been a history of previous pelvic surgery or previous pelvic infection, that might be a clue to a pelvic factor. And then, finally, we evaluate the male factor. So, lots of testing is done first, and then we'll talk about treatment options. So it's certainly okay to ask questions. And it looks like a lot of these questions are going to skip around a little bit. But in terms of testing, kind of the basic testing that your doctor is going to do would be an evaluation of your ovarian reserve. And that's really to get a sense as to how many eggs you have and how likely it is you would respond to medications. Then again, the evaluation of the pelvic factor is typically with a hysterosalpingogram, which is an X-ray, looking at both the uterus and fallopian tubes, and then a semen analysis. So that's the basic testing. We also offer genetic screening, and so that's one of the things that will be, that you will, have the opportunity to have the discussion with your physician about genetic screening for single gene mutations, and then we do standard infectious disease screening, etc. So that's the basic testing. One question I see, how do ovarian cysts affect IVF treatments? I think it really depends on the type of ovarian cyst you have. Women, when they ovulate, you produce a corpus of ovarian follicle that post-ovulation becomes a corpus luteum cyst. Those cysts typically resolve after the cycle is complete. So those are functional cysts. That's different than cysts that are present because of some more than likely non-cancerous problems such as endometriosis and those sorts of things. Those cysts, depending on the size, can cause damage to the ovaries. If they are over the size of about 4 centimeters, oftentimes we will recommend having those cysts surgically removed first. But you also have to be mindful of the fact that anytime you do surgery and remove things from the ovary, you run the risk of decreasing your ovarian responsiveness with stimulation. So that's the question about ovarian cysts. Question, I have a high FSH and a low AMH. Does that disqualify you for IVF? So this goes back to ovarian reserve testing. Ovarian reserve testing looks at the number of eggs that are potentially in your ovary. So with an FSH that is, and a lot of this, normally FSH levels increase as you get older. So it really depends on your age, but an FSH of 16 in a 30-year-old is high, but you might still respond to some of the injectable gonadotropins. The anti-Müllerian hormone is a glycoprotein hormone that's produced from the small follicles within the ovary. So if you have very few follicles, your AMH levels are going to be low as well. So I wouldn't say categorically that you wouldn't be a candidate for IVF, but you have to take into consideration age and some other factors. So if you were 35 or 33 with an FSH of 16, you might have the opportunity to try a stimulated cycle. If you were 42, probably not. You wouldn't respond, and so would probably not be a candidate for IVF. Let's see, hemorrhagic cysts following surgery, removing an endometrioma. So, when you remove the endometriomas, you can get some bleeding into that residual cyst pocket, but usually that resolves with time. I'd have to know a little bit more specifics about the ovarian cysts, so that's something you probably should discuss with your physician. After surgery, after fibroid surgery, can you get pregnant with IVF? Absolutely. Fibroids are non-cancerous tumors that grow in the uterus, and they can be located within the center of the uterus. They can be located outside of the uterus. They can be located within the body of the uterus. And the ones that are inside of the uterus or protruding into the uterine cavity or distorting the uterine cavity will actually decrease your likelihood of success. So, oftentimes we will recommend removal of those myomas before you go forward with treatment. And in most instances, myomectomy should not impair your fertility. Question, can a double trigger help with the maturity of eggs? So the trigger shot is, normally when you ovulate, you have an LH surge. So the trigger shot is we typically use is HCG in the form of Ovidrel or just generic HCG. The dual trigger uses a combination of HCG plus Lupron, and Lupron will induce an LH surge. And so the thought is that sometimes the LH and the HCG bind receptors a little bit differently and may improve the number of eggs that are mature. I don't know if there's been any studies specifically looking at that, but that's certainly something that we try, presuming that some people respond differently to LH potentially than they do HCG. It certainly can't harm anything. It may not make a difference. Next question that I see, are there tests to evaluate if the body is having an autoimmune response to sperm embryos, such as similar to how antithyroid peroxidase antibodies indicate an immune response against the thyroid? So they're not really good tests to identify kind of autoimmunity against sperm or embryos. We historically used to test sperm antibodies. And so we know, for instance, that men who have had vasectomies where you damage the barrier between the bloodstream and the testes, for instance, that can induce antibody formation. It's very difficult to test for antibodies against embryos. The body's natural response is to prevent rejection of an embryo. There can be ovarian antibodies, and certainly in women who have ovarian insufficiency and or ovarian failure, antibodies can destroy ovarian follicles, just like thyroid antibodies destroy thyroid follicles. So they're not really good tests, however, to pick up ovarian antibodies, unfortunately. Recommendations for someone in treatment for hormone-positive breast cancer using frozen eggs. I think it depends on the stage of your breast cancer. if you are in remission and have been cleared by your oncologist, one of the things that using frozen eggs, and these are more than likely be frozen eggs that either you froze prior to undergoing chemotherapy or frozen donor eggs if you didn't happen to have ovarian function, then the only way to prep the lining of the uterus would be to put you on estrogen. So we'd have to make sure that your oncologist was okay, what's okay with you doing that in order to conceive. And so usually, we're given the go-ahead once someone's in remission and it's thought that the cancer has been treated. Hopefully that answers your question about that. So, question about chances of a successful pregnancy if you've had stage 4 endometriosis and low ovarian reserve. So stage 4 endometriosis is typically endometriosis that involves the ovaries. So you may have had large endometriomas, which may have diminished normal ovarian or damaged normal ovarian tissue. There is a propensity towards adhesions and scarring within the pelvis. So IVF is usually the treatment of that's recommended, the primary treatment that's recommended. With low ovarian reserve at age 38, as long as you're able to retrieve eggs and get fertilization, then your pregnancy rates, if the endometriosis is otherwise pretty well controlled, should be consistent with that of a 38-year-old. And what we know is that as women get older, pregnancy rates with IVF decrease. So someone less than 35 might have an implantation rate of a single embryo untested for any genetic numerical chromosomes of about 35%. And then as that individual gets older, those pregnancy rates are going to fall. So at 38, if you can get embryos that go to blastocyst, I would say your likelihood of pregnancy is probably in the 20 to 25% likelihood of one embryo implanting, and then your rates would be a little bit higher if you transferred 2 embryos. If you have enough embryos to do genetic testing, then we can identify whether those embryos are chromosomally normal or not. And in that case, if you have a chromosomally normal embryo that's transferred back, the implantation rate should be about 60%, 60 to 65%. So a lot of it is dependent on your age, on the number of embryos that you have, and the development of those embryos, which then dictates how many embryos we can transfer back. Other questions? Let's see here. So what about if you've had a number of miscarriages, and what might the reason be for those miscarriages? Well, again, we have to go back to a discussion about just normal reproductive aging, okay? And when an embryo is created, the embryo itself, it starts off as a one-cell embryo. The chromosomes in that one cell duplicate and then have to divide evenly in order to develop a normal embryo. So the chromosomes, when they duplicate, they line up on the mitotic spindle. And as women get older, it's thought that the spindle breaks somewhat unevenly. So the chromosomes, instead of duplicating and then dividing evenly, they might duplicate and then they divide, but then this one goes the other direction. So as a consequence, as you get older, you start to have a higher percentage of chromosomally abnormal embryos, which is thought to be the reason for a higher risk of miscarriage as you go along. So one of the things that you may want to consider, or that we oftentimes will recommend in couples who are trying to conceive as they get older and may have a history of recurrent pregnancy loss, is pre-implantation genetic screening of embryos. And in that case, you go through an IVF cycle, we fertilize eggs, we create embryos that potentially may be biopsied on day 5, 6, or 7, post-retrieval. And then we can identify which embryos are chromosomally normal and which embryos are not. We then can, selectively transfer back embryos that are chromosomally normal, and those are the ones that have the higher implantation rate. The ones that are chromosomally abnormal, if we were to have transferred those, either they would not implant at all, so you would not conceive, they would implant and you would have a miscarriage, or they would implant and you'd find out maybe in the first trimester that there was a chromosomal abnormality. So that the pre-implantation genetic testing allows you to segregate out those embryos that are normal from those embryos that are abnormal and improve the likelihood of pregnancy per transfer, and also reduce, not completely eliminate, but reduce the miscarriage rate. How long after giving birth can you do an egg retrieval again? So, that's an interesting question. I think in some of the literature, they've suggested spacing pregnancies by 18 months. Most of the patients who come into our offices with fertility, that's not reasonable. They're trying to get pregnant and build their families. They've been trying for a long time, and they want to come back sooner. So at a minimum, I usually recommend if you need to, if you're going to do an embryo transfer, let's say, I wouldn't do an embryo transfer or wouldn't recommend an embryo transfer before you're 6 months along. And the reason being is you really need to spend some time, if you're breastfeeding, let your body go back and heal. If you've had a vaginal delivery, your recovery may be a little bit faster than if you've had a cesarean section. So I think you have to take all those things into consideration. The retrieval is less of an issue. It's really, if you do the embryo transfer and transfer embryos back. One of the things, however, is we would not recommend you doing an egg retrieval if you're still breastfeeding, just because of all of the medications that we would be giving you, and we wouldn't want those to be transmitted across the breast or through breast milk to the baby. So I would say probably I would at least give yourself 6 months. There was one of our fellows looked at data with regards to infertility patients who tended to come back sooner, and they tended to come back sooner and did well if they did conceive. So as long as you're healthy, you probably can come back within six months to a year. So the success rate of an embryo that's been tested and is chromosomally normal, the implantation rate for one embryo is around 60 to 65%. Do we offer embryo glue? We do have embryo glue available. We typically use embryo glue on request. And the reason being is it's a media that has a slightly higher viscosity. So the thought is that maybe the embryos stick to the lining of the uterus a little bit better. We don't use it routinely. But, in some instances where we've had patients that have never had any implantation, we can add that. Question. If you only have the financial ability to do one treatment cycle, what's the best option? This is an individual who has polycystic ovarian syndrome. If all other things are equal, I would probably do IVF, just because the likelihood is that you would respond well, have multiple embryos that are available for transfer, and then you could, over time, probably transfer them back. The frozen embryo transfers are much less expensive than a fresh IVF cycle. But, I think that probably what I would recommend is you talked with, one of our financial counselors, because oftentimes they can, research your insurance options or help you research your insurance options and give you some advice as to what, the best course of treatment would be. Question. My husband has frozen sperm from an unsuccessful sperm retrieval. Is IVF the best option? And the answer to that question is yes. With the frozen sperm samples that are available, the amount of sperm in any one vial is not sufficient to do things like intrauterine inseminations, so that IVF would be the best option for you. IUIs probably would not work because we would not be able to recover post-wash an adequate number of sperm to result in pregnancy. Are there any uterine receptivity tests that can be performed to increase the chances for a successful fresh transfer? So that's a little bit difficult. I mean, when you look at endometrial receptivity, there are excuse me, a number of things that we look at. We look at, first of all, take consideration of your history. Have you had any uterine surgery? Have you had any uterine infections or anything like that that could alter the functionality of the endometrium? In the absence of that, we look for structural abnormalities. In a fresh IVF cycle, the problem with the endometrial receptivity tests that are currently available is that every fresh stimulated cycle is different. So you can't necessarily reproduce the exact stimulatory response. So other than making sure that there's no endometritis or filling defects in the uterus, probably not at the present time. Most of the endometrial receptivity tests are done either on a natural cycle in preparation for a frozen embryo transfer, or a hormone replacement cycle. So that's your endometrial receptivity assay that we will oftentimes do. But it's a little bit more difficult for a stimulated cycle. One of the things that people have done in the past is, again, endometrial biopsies, and looked, you can do the ERA on a stimulated cycle. I'm just not so sure how reproducible it is from one cycle to the next. How many years can we use frozen embryos, and do frozen embryos work the same as a fresh embryo? So the frozen embryos, the embryos that we freeze, and I think most centers freeze nowadays, are really good quality embryos. We have grading systems where we look at the number of cells and the characteristics of the cells that are within the embryo. So we know that embryos that we freeze typically survive the freezing and thawing process at a rate where we recover about 90 to 95% of embryos that are frozen. There have been pregnancies with embryos that have been frozen, I know at least 15, 16 years, if not longer. So, and that was with an older freezing method, the slow freezing method. But even with vitrification, I think, we're freezing better quality embryos. We're freezing them at the blastocyst stage. So they can be frozen for many, many years. The implantation rate of frozen embryos that are, if they're chromosomally normal, should not decrease over time, and should be in that 60% range. The implantation rate of embryos that are not genetically tested are related, depend on the age of the woman at the time the embryos were created. So they can be anywhere between probably 20 and 35 to 40%, depending on, very young women have higher implantation rates than women as they get older. Are there things that you can do to improve chances of getting pregnant? That's a tough question. As long as the endometrial lining is well developed and we transfer a healthy embryo, there's not a lot that you can do specifically. We certainly offer acupuncture, and there have been some studies suggesting that acupuncture improved implantation rates. We tried to duplicate that study and were unsuccessful in showing an improvement. But still, I think it provides for a relaxing environment and reducing stress around the time of embryo transfer. We will empirically use things like baby aspirin in patients who have had multiple failed embryo transfers, or in patients who have antibodies that we think may impair implantation or contribute to recurrent pregnancy loss. Most things that you could do is just kind of healthy lifestyle, no alcohol, no excessive exercise. You can certainly exercise. But if the embryo is going to implant, it should implant. And unfortunately, there's not a lot you can do to alter that. Let's see. Patient with first cycle failed fertilization, second cycle, it sounds like you had embryos that were created, but they didn't implant. And then 4 total blasts not tested. I don't know if they've all been transferred or not. I think probably at this point you want to make sure if the embryos are chromosomally normal. And I'm not so sure what the immune protocol is. A lot of the immune protocols probably are less specific towards implantation than testing and making sure the embryos are chromosomally normal. That's probably what would be my recommendation. A 41-year-old who was diagnosed as being premenopausal. So again, the whole process of reproductive aging is something that is very difficult to change. Women in general have elevations in their FSH starting around age 40, 39, 40, 41, in that range. And then, if you look at a group of 100 women, right, the vast majority are going to follow the same kind of curve, and there are going to be some outliers. So there are some women that are going to have FSH levels that are elevated a little bit at a younger age and might be premenopausal earlier than you might expect. I think that if the ovarian reserve is really diminished, then the option, then we start discussing options such as using an egg donor, because it's usually not an issue with carrying a pregnancy. It's usually an issue with the quality of the eggs resulting in embryos that will not implant. Question about frozen embryo transfer being more successful than fresh embryo transfer. There is data out there suggesting that in some cycles, frozen embryo transfers may be better, and there are some centers that do all of their embryo transfers as frozen embryo transfers. One of the factors that affects implantation rates with fresh cycles is, one, there may be a very excessive level of estrogen, and probably more importantly, progesterone. So if the progesterone level starts to rise before the trigger shot, then the endometrial lining starts to mature earlier than you would want it to. And so then when you have embryos, they're asynchronous with the endometrium. So that's the reason for doing cryo-all cycles. Or converting some of the cycles to a cryo-all cycle. We don't convert all of our cycles to cryo-all cycles. Our frozen embryo pregnancy rates are comparable to the fresh, and they might be a little bit higher than fresh transfer rates, but I think part of the challenge you have is that we don't segregate the frozen embryo transfers by age like we do the fresh, so it's a little bit more difficult to say. But I think if you don't have an elevation in your progesterone and aren't at risk for hyperstimulation syndrome, it's fine to do a fresh transfer. Otherwise, we might make the recommendation to freeze all. Recommendations for getting a second opinion after a number of failed cycles. It's always a good idea to have somebody else look, maybe, something was missed or there could be a different approach. Oftentimes what we will do in our practice is we have a committee that meets monthly, and we review difficult cases just for that reason. So I think that, you've got a couple of options just to have a different set of eyes look at your case and see if there's anything that people would do differently. Can a person who's diabetic get pregnant? Absolutely. I think that the issue with someone who is diabetic is, number one, you want to make sure your blood sugar control is really, really good before you go through a treatment cycle. For example, an elevated hemoglobin A1C, then there's an increased risk, or if your blood sugars are elevated when you conceive, there's an increased risk of birth. So we try to wait until the hemoglobin A1C is in the 6 to 7 range before going forward with treatment. The only other thing that I would mention is it's important to make sure your renal function is normal and make sure that you have, or at least we recommend, a preconception consultation with a maternal fetal medicine specialist so that you have a plan in place during pregnancy. And then they can also help you manage your blood sugars throughout pregnancy. So, question about referring to a reproductive immunologist. There are very few reproductive immunologists, and I personally don't refer often, maybe 2 or 3 times a year. Low-dose steroids generally is something, if I felt like it was necessary, I might recommend. Again, rare that I think that intravenous immunoglobulins or intralipids are necessary unless you have, a really significant levels of autoantibodies. So, and I think it's rare that we have to resort to those therapies. I would talk with your physician about that, because it may be specific to your particular case. Again, someone who has a history of recurrent miscarriage. The causes of recurrent miscarriage most often are genetic, related to genetic, that pertain to spontaneous genetic numerical abnormalities within the embryo that arise spontaneously. But, it's important to rule out parental contribution to any genetic abnormalities. So, for instance, if mom or dad carried a translocation, that could increase your risk for miscarriage. Make sure there's no issues with the uterine cavity, such as a uterine septum or fibroids or something like that, that could increase the risk for miscarriage. And there's some other hormonal testing that can be done and some autoimmune testing that can be done. So after 3 miscarriages, I would definitely stop and do that evaluation. Make sure there are no other factors that can easily be corrected. And in the case of unexplained recurrent pregnancy loss, even with 3 miscarriages, there's still a good likelihood of having a subsequent live birth. And the risk of a subsequent miscarriage is about 25% up until maybe the 6th miscarriage. But to reduce that likelihood, most times we would recommend, genetic testing of embryos, because that's the most common cause. A comment about endometrial lining being thick on one cycle and thin on the next cycle with the same protocol. We see that sometimes, and I can't explain necessarily why that happens. I think it probably is similar to why some cycles are conception cycles and others are not in just even a natural cycle. the meds should be absorbed in the same fashion, but the end organ is not responding in the same way. So if you've tried a different protocol, sometimes you just have to be patient and just wait until you can get to the cycle where your endometrium responds. Sometimes it requires changing protocols. So you can do a natural cycle, hormone replacement. Sometimes we even resort to stimulated cycles. I think it's just, it'd be something to talk to your physician about. Is there something else that you can do differently? But I see this not frequently, but it sometimes happens, and it's very frustrating. Success rate after having a tubal ligation. So tubal ligations are a little tricky because you've gone from now having a completely normal functioning tube to a tube that's been interrupted and then put back together. So there is an area in the tube that is scarred. Likewise, depending on the type of tubal ligation, the length of the tube may or may not be adequate post-repair. So, I think that for women who are highly fertile, I don't even know if I can quote you a number because we haven't done tubal ligation reversals in years, but I would think you would probably have around a 10 to 15% chance of pregnancy per cycle. It's going to be lower than the per cycle success rate if you've never had a never had any tubal surgery. And then a lot of it's going to depend on your age. So if you're young and have a tubal reversal, I think you're going to have a better outcome because you have a longer time course to try than if you're coming in and having a tubal reversal at age 40. That's probably not the right treatment. You would be better off doing IVF. So what does a typical FET consist of? So the frozen embryo transfers can be done in a number of different ways. So for someone who has completely regular menstrual cycles and are known to be ovulatory, we oftentimes will just monitor that natural cycle. When you have a follicle that is the appropriate size, usually around 17 to 20 millimeters, when the endometrial lining is somewhere between 7 to 9 millimeters, then we would have you take a trigger shot of HCG and then do the transfer 7 days later. In women who either don't ovulate regularly or and don't have regular cycles, or in women who want to time the transfers, etc., we can do hormone replacement, where we give you estrogen orally. We can give it in the form of estrogen patches or vaginal estrogen, and also intramuscular progesterone, depending on how difficult someone is to stimulate. Wait until the endometrial lining gets to be around 7 to 8 millimeters, and then start progesterone, and then transfers on the 6th day of progesterone. So those are the typical protocols. And on occasion, you will have someone who's ovulatory who will ovulate through that estrogen. And in that case, we might add Lupron to that treatment regimen. So question, what do you do after an IUI miscarriage? I don't think that it necessarily makes a difference how the pregnancy was conceived. I think you have to look at what the gestational age was of the miscarriage, whether this was a single pregnancy loss or this was one of multiple that had been lost in the past. But the treatment is typically the same. In some instances you can have all the have all the tissue pass spontaneously. In other instances, you'll elect to have medical management. In other instances, dilation and evacuation just to remove the tissue manually. With the manual removal of tissue, we can send it off for genetic testing, so that may be a reason to choose the surgical approach. But, I don't think it necessarily matters how you've conceived it, when we talk about how we manage the miscarriages. I'm not sure I understand the question. Can B3 prevent miscarriage? I'm sorry, I don't quite know what you're referring to. So the question is, I mentioned genetic testing for screening chromosomes for increasing the chance of success. And whether there are additional tests that we can do on blastocysts to help predict their expected outcomes. That's an area of ongoing research, quite honestly. I mean, people are looking at metabolic profiles of embryos. They're looking at non-invasive ways of doing this genetic testing of embryos. So there may be ways that we can look at embryos differently. We can look at rate of embryo development under a microscope where once we've documented fertilization, we can just watch those embryos under a camera and not really manipulate them at all. So far, we haven't come up with a non-invasive method to really give us more insight into embryos, but I think that's where a lot of the research is being, embryologic research is being done in terms of how can you non-invasively evaluate embryos that go to blast and decide which ones are better embryos. So I would say we've got to stay tuned. IVF success rates after tubal-ligation, going back to that question. For a woman who's had a tubal-ligation, who's doing IVF, her chances of pregnancy are really going to depend. Probably the most significant factor is going to be her ovarian response and her age. So women less than 35, single embryo transfer would have a 35 to 40% chance of pregnancy. As you get older, that statistic is going to decrease. By 40, your chances of pregnancy, again, embryos that are not tested, maybe 15 to 20%. With genetic testing, you can get the implantation rate of an embryo up to 60%, 65%. So what about supplements? And will they improve egg quality? So there are a lot of supplements that people are recommending. I think that I'll talk about a few of them. Some of them I don't use, and so I'm not going to speak about those. But coenzyme Q10. So the theory behind coenzyme Q10 is it's a cofactor in the metabolic pathway of mitochondria. And there was a lot of research that was initially being done on cytoplasmic transfer and mitochondrial transfer, trying to improve the cytoplasm of the eggs of older women. So that research was stopped by the FDA. But the thought is that coenzyme Q10 can kind of improve the metabolic machinery within the egg and therefore improve the development of the embryo to blastocyst. So for women especially who are in the 38, 39, 40, that may be beneficial, a beneficial supplement. It certainly is not a supplement that's going to have any adverse effects. So I'm always comfortable using that. Myo-inositol and D-chiroinositol are cofactors in the insulin pathway. So there's some data suggesting that those supplements may improve ovulation rates in women who are anovulatory with PCOS. So again, we would recommend oftentimes using those. I don't know about an acetylcysteine. I don't really use melatonin. DHEA, there's some evidence to suggest that maybe DHEA improves estradiol response, which makes sense. DHEA is a precursor. It's an androgen, so it's a precursor to and can be used as a substrate for estrogen. So that makes sense. Some of the studies suggested that the supplement DHEA will improve egg yield. I haven't seen that personally, and so I don't usually recommend it. I don't necessarily dissuade patients if they want to take it, but it's not something that I recommend. It has a lot of side effects too in terms of hyperandrogenic symptoms or side effects, which hair growth, and those sorts of things, which I think you have to be careful about. And then vitamin D, I think there's increasingly more evidence that having normal vitamin D levels is a good thing for many conditions, including your fertility. So I'll just recommend mostly that just vitamin D supplementation. Most people are vitamin D deficient in the Northeast anyway. And usually, unless you're severely vitamin D deficient, a dose of maybe 2,000 units a day is sufficient. So question about, going to egg retrieval and having 16 eggs fertilized, but then poor embryo development. And how do you determine if it's an egg issue or it's a sperm issue? Sometimes we can't know if this eggs and sperm look completely normal. In general, the development of an egg or an embryo to day 3 is reflective of kind of the maternal genome, and it's not until the embryonic genome gets turned on and around day 3 that determines development to blastocyst. So there may be some component of, both egg and sperm. Sometimes we can't identify the specific cause, and we might look at, fertilization didn't seem to be an issue. In some instances, we might, because we don't really have any other testing to, at least at this point, to really determine, you might talk about, do you change the sperm source or those sorts of things? But I think that's a very difficult conversation for many couples. If it's only one cycle, I would try doing another, a cycle again, and maybe changing the stimulation and seeing if that changes the response. Someone was asking about the cost of IVF, and I think that cost of IVF varies. In general, I think for a cycle of IVF, including medication, someone can expect to spend out of pocket maybe $14,000 to $15,000. So, and then if you've got insurance, many insurance companies will cover that. But I think that you would be best to speak with a financial coordinator, because then there are add-ons. If you have to add on ICSI, that adds on to the cost. If you decide to do genetic testing, that's going to add on to the cost. What can cause the fallopian tube to not be visible? I'm assuming that this question is on a hysterosalpingogram. Sometimes when you're doing that, the HSG, which is the X-ray where we're putting dye into the uterus and then taking pictures, sometimes the uterus will go into spasm where the tube is inserted into the muscle, and so sometimes that tube just won't fill. There could also be a proximal blockage, meaning that there's blockage of the tube right where it connects to the uterus, and that could be a mucus plug or something like that. So there are a number of reasons where a tube might not fill. I guess the other thing is if it's been surgically removed, you won't see it, but you would know that in advance. If the contralateral tube is completely normal and there's no history, I usually don't worry about a tube that we've not visualized on HSG, because most instances it's just spasm. Just a historical note, we used to do things called proximal tubal cannulations, where we would, under X-ray again, go in and put a catheter that we could put in towards the tube and try to see if we could flush it out. And oftentimes it was just a mucus plug or something like that. We don't do that anymore. But by and large, if there hasn't been any surgery on the uterus, it probably is just a spasm. Question about blood group and whether blood group discordancy, I guess, would be a couple or reason for miscarriage. Typically, that's not the case. The body has a pretty nice immunologic way of identifying an embryo as foreign and protecting it. So blood groups should not cause miscarriage, or differences in blood groups should not cause miscarriage. One of these with the comments is in Spanish, and I don't. Oh, maybe I can do the translation. If insurance does not cover the process, what's done in that case? Then we would have you talk to our financial coordinators to discuss what the costs would be to you. Oftentimes, there are couples that might be eligible for certain discounts, for instance, if you're in the active military, or if you can document an income below a certain level. There are also loan programs that we can direct you to where you can get loans to cover the cost of treatment. Can smoking cause low sperm count? There is pretty good evidence that smoking can impact many different semen parameters: sperm concentration, sperm motility, sometimes sperm morphology. Moreover, there's data that in couples who smoke and doing IVF, that the metabolites of nicotine have an adverse effect on embryo development in culture. So many of the insurance companies now are requiring that couples not smoke before they do an IVF cycle. So that's been a barrier for many individuals. And we certainly support that recommendation because the IVF success rates were lower. Do you see a lot of people with septate or partial septate uteruses with recurrent miscarriage? And that's one of the uterine abnormalities that will cause recurrent miscarriage. And while some women with a uterine septum can conceive and have a full-term pregnancy, the miscarriage rate can be quite high, in the 80% range. And surgical repair, which typically can be done hysteroscopically, where you can go in and just remove that septum either with scissors or with cautery to normalize the shape of the uterus, will improve your pregnancy outcome substantially and almost normalize it. So for those patients where I identify septums who are either undergoing fertility treatment or have a history of recurrent miscarriage, we would recommend surgical repair. We've got lots of comments. Let's see. Can an ectopic pregnancy and minor surgery to remove it cause unsuccessful pregnancies? I think the surgery for ectopic pregnancies is either a salpingostomy, and in a salpingostomy, what happens is you open up the tube, remove the ectopic, and then let the tube heal it on its own. And so in that case, the tube generally, or maybe functional afterwards, but it's functional knowing that there's that scar, so there's an increased risk of recurrent ectopic there. That's probably 15 to 20%. In other instances, the tube has to be removed in its entirety. Having an ectopic should not impair your ability to have a miscarriage, or another pregnancy or a miscarriage. Sorry, I scrolled back. Oh, I see Emily, who's one of our marketing folks, has put in some information about financing options for those individuals who are asking about cost. Thank you, Emily. I'm trying to think if there are other questions that I've missed. I've been scrolling through, and somebody asked a question about any advice for a successful future insemination cycle. This is an individual who ovulates monthly, has had normal testing, and everything else looks good. So, and she's 43. I think one of the challenges at 43 is that even though you're ovulating regularly, the likelihood of pregnancy is probably 5% per cycle. With IUI, probably not much higher than with IVF. So it's just a matter of continuing to try, if that's the only option, just because you have to hope that you're going to run into that good egg. But the vast majority of embryos that are created tend to be chromosomally abnormal, and that's part of the reason that women are not getting pregnant. And if you're open to consideration egg donation, then you can change those success rates, but that just has to be something that, that you're open to doing. Well, it looks like most of the questions have stopped. So, it's about 8 o'clock. I'd like to thank everybody for joining. This has been fun. I hope that I was able to answer, all of your questions, or at least give you some insight into many of the reasons why you're having difficulty conceiving. And, obviously, if you've got questions or, wanted to talk with one of either me or one of our physicians at Boston IVF, there are, you can go to our web page to identify all of the numbers that you can call to make an appointment, just so that you can be seen. And then we do have nurses that if you have just a question, sometimes they can answer that question and or direct you to the appropriate resource. So thank you again.